Okay, good morning. So we're going to start the session. Let me present this case. I think you had some time to look at it, but I want to thank Selvi, Roy, Sylvia, Sriram for helping me with this presentation. And I want to thank Dr. David Graham for joining, and John Stoline for his support. And I also want to thank Mr. Charles Butt of HEB for the grant, Angela Deal, and my institution. So this is the story. This is the gentleman I just took care about a couple of weeks ago. He's a 70-year-old man. He was referred for endoscopic mucosal resection. He's been good health with a few problems. Hypertension, had ischemic heart disease, has 2 coronary stents. He's on aspirin and Brilinta. He has no family history of colon cancer. He's not a smoker. He drinks about 2 drinks per week. So one thing I need to share with you is this is a gentleman I took care about a year ago, and I did a cecal polyp resection, and that was a complete resection. And after that resection, I told him that, for his own convenience, to go back to his gastroenterologist to do the follow-up exam at a year later. Usually I do them at 6 months and 18 months. And at that time, I look for other polyps. And if there are other polyps, I remove them. And once the colon is cleared of all the polyps and has no recurrence at the site of the EMR, that's when I send them back to their referring physician. But in this gentleman, to make it convenient for him, I let him go back. So what happened was, when he went back to the gastroenterologist a year later, that was just a few weeks back, he had his first exam following the EMR. The cecal scar looked good. But on the way back, the gastroenterologist saw this lesion in the ascending colon that you see here. And he put a tattoo. He didn't biopsy. We work very closely. When he thinks that it is not cancer, he doesn't biopsy to make it easy for me to resect. And then he sent this patient back to us. So I'm going to share this video. As you can see here, this is the lesion. And he has done one thing that is very helpful to me. That is, he has put the tattoo away from the lesion. He didn't put it close to the lesion. It's not uncommon that some of the gastroenterologists in the community may decide to put it very close to the lesion to the point of infiltrating the lesion that causes a lot of scar tissue. So the reason before I play this video, I wanted to show you that he has placed the tattoo away from the lesion, which is the right thing to do. So if you want to place a tattoo, you place the tattoo about 3 to 4 centimeters away. You create a saline bleb, and into that bleb, you put in the tattoo. And you put the tattoo in the same plane as the lesion and take a picture showing the tattoo and the lesion so that whoever is going to take care of that patient will find that polyp easily. So Roy and myself have been talking about how to teach EMR and assess polyps. So Roy is going to look at this lesion and comment, and he goes through a series of steps in terms of processing a polyp like an expert, and he will share those thoughts with us. So let me play this video, and then once Roy is ready, I'm going to allow him to share his thoughts. So Roy, you may want to comment on this as we go along.
Okay. So here I just started by looking from far distance and then trying to understand what is the overall general appearance of the lesion. So what he's trying to do in the beginning, which could save a lot of time, is trying to decide, is this malignant polyp that has a lot of cancer in the submucosa. So there are a few signs for that, such as if there are like folds coming, converging towards the polyp, if the polyp makes the fold very, very thick, what we call as the expansion size, if the polyp itself is bulging. So he's trying to assess all of that. Most of us do not immediately turn on the NBI and then come close because the first step, which is examination of the general appearance, is actually critical and can save time. So here he has turned on the NBI and he's trying to interrogate the mucosa, looking at the surface pattern and the microvascular pattern. So he's trying to see, he had this thinking in his head that this is not a submucosally invasive, meaning that not a lot of uh, cancer inside, if there was any. And he said, okay, let me try to interrogate the surface and then confirm it, that my intuition that this is something that I could cut is correct. So he used the nice classification. He's looking for an area that's amorphous. And he says, doesn't look like there is any. Let me look at it again from one side to another side. So he's looking from that edge on the left and then towards the right edge.
So Roy, what I understand from your thought process is step one, you want to ask yourself a question, is this a submucosally invasive cancer or not, right?
Correct. The step one is like basically saying, is there any findings that tells me that this is blatantly a submucosally invasive cancer? And you said, no, there's nothing. And then you move on to the step two and you say, okay, let me confirm. Let me just look at the surface in a near focus and then confirm that.
Okay. So actually, for those of you who are looking at it, I want you to show this. So here, as the video is running, I want you to look at it at the right upper corner. Right now, it is with this. This is white light, and then we turn NBI with a regular regular focus, and then here I press the near focus button. This is available in the Olympus scope. I don't know about the other scopes, so I cannot comment. But when you have a near focus, it helps you to have the distance between the tip of your scope and the lesion at a particular short distance. If you are far away, you won't be able to see that. And for that, your cap is going to help. So we talked about whether there's an obvious submucosal cancer or not. Here it's not. Then we used a narrowband imaging to say that there is no surface or vascular features to suggest cancer, right? And then what do you think is the lesion? What is the next
so
step?
we are also using so the first step, right? You're looking at is there any full convergence? Is the lesion looking like having expansion on this. We will show you the diagram of this. And then the second lesion, and the second step, you also look at the morphologies. You're trying to confirm all of these findings, looking at the morphology, looking at the size, and then you look at the surface and microvascular pattern. So Raju is asking, what is this lesion? And the answer is that this is really a flat lesion that's like on top of a fold. It's a clam. It's like a offer lying a fold. So it looks like a sessile, but it's not, because it is like if you look at the left side, there is this one fold that's going across, and then there's this polyp on it. So in some views, it may look like a sessile, but it's not. It's just like a polyp that's draping a fold.
Okay.
So this is a lateral spreading tumor, and it's flat elevated. We classify it, and has a surface pattern that is nice type 2. And all of these things tells us this is all good to go for an EMR.
Okay. Do you want me to stop sharing and you want to share your screen and show that your slide of how to work through?
Oh, I don't have the slide with me.
Okay, we'll do it next time.
May I have a short comment?
Please.
I just want to echo Roy's assessment of this lesion, in the sense that I think it looks to me also like a laterally spreading tumor, which is spreading over 2 folds. And at this point, I can't say exactly what type of laterally spreading tumor it is, because as we have mentioned previously, sometimes you need to stretch the lesion in order to assess the subtype. So looking carefully, I don't see a nodule or a depressed area which are associated with submucosal invasion, which is good. So I think this is a lesion which can be resected by endoscopic mucosal resection by EMR. And of course, we prefer to resect it en bloc, because we never know what's exactly the histology. So I think it's a small lesion, about 1.5 centimeter in size. Why do I say 1.5 centimeter in size? And please correct me if I'm wrong. I have learned that lesions which are spreading over a quarter of the circumference are about 2 centimeters. And in my opinion, this lesion is a little bit smaller than a quarter of the circumference. So it should be something like 1.5 centimeters in size. So we can resect it en bloc. That was
all right.
my point.
Raju?
Yeah.
Can I ask just as a teaching point, maybe for the nurses and techs that are on the Zoom call?
Mm-hmm.
In terms of you said that the patient was on aspirin and Brilinta.
Mm-hmm.
And so if you're doing an EMR, what kind of instructions did the patient get in terms of bowel prep and holding their antiplatelet agents?
So why don't you discuss?
That's a very good point.
So when did the patient last take their Brilinta? Because this is a patient who's coming for a colonoscopy. Sorry, go ahead.
Yeah, there are 2 things. I'm glad that you brought it up. There are 2 things that we need to keep in mind. Patients who are on coronary stents and they are taking 2 medications to prevent the clotting of the coronary stent. We always make sure that they continue, and especially if the stent has been there for quite some time. There are different recommendations. If it is a bare metal stent versus a drug-eluting stent, there are different time intervals. To be honest with you, I don't exactly recall. It's about 6 months or 9 months, but
6
I usually
months.
check my notes and confirm that. In terms of the stent, we must tell the patient to continue their aspirin, and whatever procedures we do, we continue their aspirin, and that will keep their stents patent. In terms of Berlinta, I believe this patient stopped about 5 days ago. Usually what I do is I do not recommend when to stop. When I see these patients in the clinic, I tell them that, okay, you reach out to your cardiologist and let your cardiologist make that call. Because we don't have... we don't have all the details about that patient. So I leave it to the cardiologist to do that. All right.
Okay.
So, okay. So let me, you guys saw this lesion, and let me ask Sriram, Sylvia, and Selvi, and Roy. What will you tell your assistant in terms of what you're going to inject, what type of snare, what type of settings will you use? Sriram.
Thank you, sir. Good morning, everyone. In general, I use saline with 1 in 100,000 epinephrine by default. So I take a 100 cc bag. I tell them to put an SCC of epinephrine. That makes it 1 in 100,000. And initially, I inject saline, and once the plane is confirmed, we inject it to lift the lesion. And the alignment of this lesion is more linear than oval or round. So positioning of the lesion for the snare placement is crucial. And as Dr. Silvia mentioned, this is about 1.2 to 1.5 centimeter lesion. So it should be able to come out with a 2 centimeter snare in one piece.
All right, Sylvia, what do you do? What's your injection? And
I think I would follow the same instructions as Sriram mentioned. I would add a few droplets indigo carmine into the saline to improve demarcation of the borders of the lesion once it is lifted. So that's the only difference.
okay. And Selvi.
Yeah, we don't have access to the staining agents. That's my problem.
Mm-hmm.
All right, Selvi, what do you do?
I generally by default do methylene blue and saline. I don't routinely do epinephrine. And I would probably start after injection with a 10 millimeter hot snare. Both to get I use it kind of as a ruler. So I'll open it up and take a picture at the lesion to see if it's, to gauge the size of the polyp.
Okay. Roy?
I usually use the ORICE. In the past, I usually use saline and a little bit of indigo carmine. There is a point that we had written a while back about the importance of trying to avoid methylene blue, which is to say that methylene blue is actually an agent that can cause inflammation if you inject. And in a very small number of patients, it can cause almost like an allergic or painful reactions. Methylene blue is used as an agent when they perform on sentinel node findings in surgery. And based on those observations, people have seen that people develop reactions such as intense inflammation. And then we had a case way back whereby such was observed. So then from then on, we say, why do we do that when there is an agent that is safer? So based on that, when we use saline, we just use indigo carmine.
Okay. So I'll share, I think as we present this video, I'll share what we do. We typically, for a lesion that is of this size, right, is about 15 millimeters. So in those cases, I asked the anesthetist to give us two 10 cc saline syringes, and then put in a little bit of either indigo carmine or methylene blue. And if somebody has a coronary artery disease, they have stents and other things, I try to avoid putting epi. And small amount of epi may not make any difference, but that's been my practice. And as you can see here, I've decided to inject from the other side, and we will play it one more time. Basically, I try to not inject multiple sites. I try to inject one or at the most two sites, and direct my injection to make the polyp come into a very favorable position. Let me ask, Roy to comment on this as he goes through this thing.
Raju, can you allow me to share my screen for a second?
Okay. All right, let me.
Okay. Can everybody see the diagram now?
Mhm.
Is it clear?
Yeah.
Yeah. Okay. So this diagram is a diagram that about 7 of us from around the world who does EMR made. And it's a diagram that tells you how we think about when we approach a polyp. So especially the larger than 1 centimeter polyp, because once it's larger than 1 centimeter, there is a good possibility that it may be malignant. And we really do not want to cut those that are malignant and have a lot of cancer cells underneath in the submucosa, because those kind of cuts will not be very helpful. The patients eventually will need surgery, and the cuts itself is associated with the risk of complications. In patients like this especially, you don't want to cut if it's not going to benefit the patient, or if the patient doesn't really understand that, oh, this cut is not going to be very curative. So the first question that you want to know is, does this lesion have features that tell you that it has a lot of deep or submucosal invasion? So that is seen by fold convergence, expansion. So what do you mean with expansion? One day we are going to go through this and show you examples for it. But expansion is that this polyp would have been very ideally, you have this polyp on the fold, and the fold at one point looks very thin, and then suddenly if it was expanded, the fold becomes like so wide. And you say, why is it wide? Well, the reason why it's wide is that underneath that area there is a lot of tumor, and then the polyp looks stiff or rigid. It has this uneven surface at the bottom. This one doesn't have it. And then if it was like bleeding by itself before you start. Now, the last part is ulceration. So superficial polyp, meaning that it is not frank cancer, does not ulcerate, except in inflammatory bowel disease. So something that's ulcerate, you need to be like thinking 10 times before you do anything to it, because ulcerated findings is not part of the superficial neoplasms. Ulcerations is part of the deep cancer. Okay, you start with that, and then you decide, okay, this is superficial. This is the one that I can cut. And then you start thinking like, what is the size? Does the size tell you that it has a lot of risks or not? And then you start recording with the location and all that. And then you confirm the border. and you say, okay, let me just make sure that the morphology is something that is benign. One classification that we use for that is the LST classification. So we've done all of that, and then we do the nice classification. We come close, we interrogate the surface, and we interrogate the microvasculature. If it's like nice type 3, then you say, oh, this is a deep submucosally invasive tumor. This is not a subject for endoscopic resection. So then you move to the diagram on the left. Otherwise, you stay on the right. And then the next level, you say, can I safely cut the tumor now? And that depends on many aspects, which is like what we just talked about, which is how about the patient's anticoagulation? How about the patient's coronary disease or any other diseases? What about the team that I have today? Can they actually help me? Do I have like 15 other colonoscopies that will make me uncomfortable in cutting this lesion, and I will not do a good job? Maybe I should be doing this job next time. So all of these things have to be assessed. And then if you say, no, I'm all good. I'm going to do an EMR. I have the team. I have the patient is safe, blah, blah, blah. And then you perform the resection. It is really not very hard to go through this diagram, but it's unfortunately this diagram has never been produced explicitly. I look at our publications on this topic for the past 20 years, and we always just superficially write this. We never really tell us about the deconstructed steps. And we wish now to share this diagram, and we took the steps to bring together thoughts from many people to create this one piece of the diagram. So there it is. Take a look at it, and hopefully it's useful.
All right. I'll take it back.
Yeah.
Thank you. All right. So now that we injected, you want to comment on the injection? Yeah.
Sure. The injection for this is best done using the dynamic injection. So the dynamic really can be done from the front or the back in here. But Raju is elegantly just wanting to show, like, look, I'm going to see what is the back part of this polyp, which is the back of the polyp on the fold. And he's going to inject, he's going to suction the lumen slightly. He's lifting it up, lifting it up, suctioning a little bit more, and then lifting it up. Sometimes at this point you have a readout, and readout is okay because you know where the tip of the needle is. He says, okay, looks good. The polyp rise up. There is no non-lifting sign. He's going to inject just a little bit more. He says, well, this patient is a high-risk patient. Let me just inject enough because any nicking of the muscular diastropia is bad for this patient. He didn't really want to do that. So he injected enough. Probably at this point, he's looking at the bottom part of the polyp and trying to see now, did that part have enough submucosal injection or not? So he has look at it all and be satisfied with it.
So one thing is for the group to understand is the bigger vessels are in the deep submucosa. So if you have a good lift and you cut and you stay away from the deep submucosa, you are likely to avoid injury to the bigger vessels. So what we did was we used a 15 millimeter snare, and we set endocut Q 313. And the key is the assistant needs to work with you and open the snare closely, slowly, and also close it slowly so that the snare doesn't slip. And you want to make sure that you have enough of normal margin around the polyp so that you have a so-called R0 resection. That is, margins are clear from any polyp tissue. So with the 313, Endocut 313, that's what we use to cut. And fortunately, we had no bleeding, and it's not a big polyp, but we wanted to show you how to do a good en bloc resection. There's a small vessel there, but it's not bleeding. It looks like it's cauterized. Last week, we talked about APC of the edge, but I wanted to show you in this video how to do snare tip soft coagulation. The reason I wanted to bring this point here is, if you ask me, how do you decide whether you want to do snare tip soft coagulation or APC? Although this was complete en bloc resection, and I think that the margins were clear, I felt that, okay, let me try and cauterize the edge. And the operating field has been relatively stable. And I was able to place the snare on top of the edge nicely, flat, not like just one wire, but both the wires as the loop, with a setting of effect 4, soft coagulation, and 80 watts. Once we do this, then the question comes is, how do we close? I think, just 1 second, I wanted to see, 1 second, okay. So we decided to close the defect for basically 3 reasons. He is 70 plus, older age increases the risk of bleeding. Then the lesion is in the ascending colon. So lesions in the left colon are at a higher risk for bleeding, delayed bleeding. And third thing is he's going to go back on antithrombotic medication. So for all those reasons, we thought that we should close. And the second thing is you also have to keep in mind when you're practicing what is happening around you. You know, that is something you have to keep in mind when you're managing the patients. Right now, we are in the midst of a COVID surge. Anytime a patient comes back with a bleeding, it's a bigger problem because hospitals would have to go through a lot more issues when it comes to managing an emergency endoscopy. Because if somebody is bleeding and you need to do an emergency endoscopy, you have to assume that the patient coming back into the hospital has COVID until proven otherwise, and deal that case as a suspected COVID. That means you have to put in a lot more resources to take care of the patient in preparing the room, anesthesia, people in the hallway to support. It is a lot more bigger operation. So given that thing in mind, you have to manage your cases so as to avoid getting into trouble. Okay. So I want to share with you, this is a video that I edited it to help those who want to learn about how to close defects. And as you can see here, the clip was open, and then I pulled the clip back to the scope. You don't see the lower lip, you only see the upper lip until the clip is closing. And when you close with a clip, you should not, a good clip closure you will not see any gap in between the 2 blades. As you can see here, right? There is no gap in between the 2 blades. If you have a gap in between the two blades, that clip is going to fall off very quickly, and it is not going to create the mechanical hemostasis that you want. So I want to make a comment here that is Tom Slocum. Tom, you're here. I wanted you to keep this thing in mind. We talked about how does it matter depending, and how do you choose a particular clip? And when I'm doing a difficult closure, whenever I'm doing a difficult closure, here the closure is not difficult. I try to pick a clip with a longer stem. The longer stem would allow me to reorient my closure by pushing on the stem of the clip with my cap. So you can see this thing nicely demonstrated here. And I wanted to make that comment so that Tom could observe some of the points that we discussed in the endoscopy suite. So as you can see here, we are applying the clips. The clips were applied very deep, and I'm applying them very close because I don't want to risk any delayed bleeding. As you can see here, this is a long shot, right? You don't want to do a long shot, which is an uncontrolled closure. So I backed off. I came back to the defect to be very close to the defect. And as you can see here, I'm hanging on to the previously placed clips by pressing down and slowly walking back millimeter by millimeter, and allowing the breathing part of the colon movement to help me position my clip so that I could apply a deep approximation. So you could see that how I'm doing that. I'm not in a rush, so I'm taking my time to apply the clip nice and deep. If you don't use the clips properly, you're just wasting your money. You know, you want to have a deep approximation. That's the most important thing. The other thing is when you close the defects to prevent bleeding, just a partial closure has been shown to not be very effective compared to complete closure. Complete closure means very little gap in between and mucosa to mucosa. That was based on a beautiful Spanish study that was published a few years ago. So as you can see here, I'm just trying to close and get the edges also. So, but one thing is you realize as I was closing, there was another small lesion proximal to this closure. And I'm going to show you that. So any comments on that, Roy?
I
Sylvia,
think we need to discuss a little bit about the deconstructed part of clipping. So what Raju has shown you is that number one, clipping ought to be done with the clip close to the endoscope. When it's far away, you lose control and you also lose strength because then the clip, the cable can be bent if it's too far out. So you want to clip it just as the clip comes out from the working channel. So that's number one. And here the best is to clip it tangentially because then you remake that that fold which he did. And then as he clipped, actually what he did, there's this micro deconstruction that he didn't really tell us, which is he opens, he comes to it, and then he has the lumen soft, so that way the lesion can easily just be grabbed by the clip. And the clip is applied. As it's being applied, he pushes the clip outward slightly to make sure that the clip grabs as much tissue as possible. And he has a very good technician or assistant who's helping him, and that person, he or she, basically just steadily close the clip. Nobody is in a rush. Nobody clips it with a sudden jerking movement, because when you do that, then the tissue tends to just fall out. So it's done slowly, steadily, I call it. It's like push it slightly, suction the lumen to make it collapse, and then push it out, and then simultaneously, the assistant closes us in a very steady fashion. When there is a possibility that he made a mistake, which is the clip being too far, then he take the time to readjust. So by doing that, then all of the clips are placed very deeply into the tissue and is grabbing the tissue into the deeper layer of the submucosa, if not in the muscularis propria. And that's what going to allow the clip to stay the longest.
Okay. Thank you. All right. So the other thing is, one of the things that I wanted to point out here is, as I was doing the case, I found a small adenoma by the side of that edge, right? You see this? So it's important to clear that because otherwise what happens is, once the area heals and you come back to biopsy the scar, you may see this adenoma then, and you wonder whether you had recurrence there, at that time. So if there is a small adenoma by the side like this one here, you want to get rid of it. But how to get rid of it? I think that is the next step. We're going to talk about that. So here, I want to show you something. We thought that we'll take a biopsy and remove it. But then I thought that, okay, if I'm going to pull that with a biopsy, will that loosen my clips, right? That is very close to the clip closure. So for that reason, what I decided was to take a hot biopsy forceps. And once I closed onto that lesion, lifted it up, changed the current setting to endocut I, 1, effect 1, duration 3, and then interval you could put anywhere, 3 or 6, doesn't matter. So, and then lift it up, and then just gently tap to have the electrical current to cut it, rather than mechanical force to pull, because I was worried by pulling, I may loosen the clips. And having said that, I decided that how about we close that area also, because I don't want that to bleed. Because recently I saw a patient where I cut a big polyp and then I cut a smaller polyp, and then that ended up causing the bleeding. So we decided that we'll close. Before that, you can see there's a little bit of a gap between these two clips. I wanted to close that, and I didn't want to get that edge. So as you can see, we're gently moving. So the key is, when you're doing EMR, you have to have a good scope tip control. And the way to get a good scope tip control is, every time you do the colonoscopy, you take that screening colonoscopy as if you're doing an EMR. So you'd want to reach the cecum in 60 to 70 centimeters every time you do that, rather than rushing in with putting long loops. If you have long loops in the sigmoid, you will not have this fine control of your scope tip. So it's very important to take every endoscopy that you perform, every screening colonoscopy that you perform, as if you are going to do an EMR and you want to have a good scope tip control. And if you have that in mind, one thing you should do is reach the cecum in about 60 to 70 centimeters. In most people, you can reach the cecum in 60 to 70 centimeters. And if you do that, then you will have a much better scope tip control. So that is one point I want to keep in mind. And as you can see here, there's a small bleeding vessel in the base, right? You see that there? And you also see the benefit of having a cap. I don't think I could have done this procedure if I did not have the cap, because the cap is able to push those clips around. And these long stem clips from Boston Scientific are very helpful when you want to use the long stem to move the defect in such a way to apply better clipping. So I wanted to make that point. I don't have any conflicts of interest with Boston Scientific, but I wanted to make that comment to let you know. So
Raju,
yeah.
can you yield for about 3 minutes? I can explain about the classification quickly.
Yeah.
And
okay.
One point I wanted to share with everyone is that Raju and I, yes, we did not talk about what type of snare we use for these. But there's one thing that I would like to share is that there is no way that anyone could do this resection with the flimsy snare. It just won't work, because that opening that Raju did with the snare from the tip of the polyp to go down requires the snare to be pushed down onto the polyp. And if the snare is flimsy, the snare will flip up and you're going to be like so frazzled trying to cut it. So this point, has not been understood by many companies. And for the 15 years we've been doing this, there is really only a very select few snares that allows you to have this stiffness to do that.
All right, you can share your screen.
Yeah, so you see it now?
Yeah.
Okay. So here is the classification that we wanted to talk about. So the Paris there's really two classifications that are important in these thought processes with the diagram that I had shown you. So the first one is the Paris classification. I think everyone understands the Paris classification now. You think it as polypoid and non-polypoid. The polypoid, I think the one thing that we now need to understand is that we don't really talk about subpedunculated anymore. That is all blended together into the pedunculated. The non-polypoid is really thought as like the flat and the depressed. And the flat is really the one that's completely flat, or it's just the tabletop flat, which is the slightly elevated shape. And why do we put them all together? Because it turned out that in patients without inflammatory bowel disease in their colon, the completely flat one is so rare. And way back in 2008, when we published the JAMA paper, we said, well, if we talk about superficial elevated, slightly elevated, all of this, the audience will not get it. So let's just put it together as a flat, and the editor agreed to it. Just say this is all just flat lesions, which is the tabletop flat and the completely flat ones. And then as the polyp becomes larger than 1 centimeter, the non-polypoid ones especially will have additional, it will have a mixture of morphology. Some of them will have like a combination of the tabletop flat, slightly elevated, and a depressed part. Or maybe it's just slightly elevated and then there's a bigger nodule. So these things becomes like a bit harder for many people to say, well, is this a combination? So should we name it as slightly elevated hyphen depressed? It's like going to be like just the name alone will be so long. So the lateral spreading tumor classification, the pragmatic classification, helps us to make it simpler. And really, what you say is that for those people, those polyps that have a general morphology of non-polypoid, and they are larger than 1 centimeter, we want to just call them using these LST classifications. And then there is, you say, okay, what are those? Well, you could stretch these tabletop ones, and that will become the flat, elevated, non-granular. So these are the polyps that seem to be like the tabletop, that the top is just like smooth. And you say, okay, there's the big one. That's the LST non-granular, flat elevated. And then there's the ones that has a slight dimple along it. And why is it so important to know, well, is this like tabletop flat? Is this having a pseudo depressed? Well, it turned out that whatever polyp has a depression, it is a bad one to be having, because there's a lot more risk of submucosally invasive cancer, and cutting them is a horrendous job to do. So trying to understand this is very, very important. So now I'm done with the pseudo-depressed. Then you look at the ones, these polyps that look like a polyp that has maybe 50 or 100 of sessile little bumps on their surface. And those are the LST granular. Okay. And if you say, well, you know, these sessile bumps, when they're just like 5 millimeters, and then we do the standard cold snare, and we never see any malignancy in it. If you have like 50 of them, well, the risk of them to have malignancy is going to be slightly up, but it's not going to be as high as anything else. So it is important to say, well, if these little bumps are homogeneous, they're just little sessile, you know, together spread it around over like 2 centimeter area, then we call them, those are the elastic granular, but they're homogeneous. They're just a bunch of sessile lesions. That risk, that polyp, you can cut it in piecemeal, and then the risk of cancer is really, really small. Okay, so among all of the LST, that would be the smallest risk. Then you say, oh my goodness, this one is like mainly homogeneous, but then there is like one big bump. What is one big bump? A big meaning like 1 centimeter or larger. And it is important to note that, because in this big bump is where, just like in sessile lesion, is where the malignancy, the submucosal invasion would be residing. So that area needs to be cut separately, and then put to the pathologist separately. The rest can be cut and put into one bottle. Then you tell the pathologist, please make sure you do multiple cuts on this one, because I'm worried that there is a malignant polyp in it. So, so you look at these 4 different subtypes of lateral spreading tumor, and you say, the pseudo-depressed, if I see something like that, I need to be very, very concerned, because that's really like a depressed lesion, and that has a very high risk of malignant polyp, and cutting it
will take a lot of time. If I can do an ESD, I should do an ESD on that. If I cannot do an ESD, I shouldn't be cutting this into small pieces. Then you say, well, the next one that has a higher risk is this LST granular with a mixed nodule. The big nodule is like where your area of concern is. And then you say, okay, there is this tabletop flat. That's also very difficult to cut. It typically has submucosal fibrosis. I need to really have the time, the expertise, the team to cut this. But thank goodness, you know, there is no pseudo depression. Anything depression is bad sign. Then you have the homogeneous, which is actually quite common. And you say, oh, okay, that one is easy. I don't want to be sending anybody with this homogeneous granular to the surgeons, even though it could be like 4 centimeter, because their risk of containing submucosal cancer is very, very small. Okay, let's just go take the time and cut it well. I think that's the message of these classifications. And I'm really glad that the classifications now is increasingly recognized. We are like have moved 12 years since then, and now we are willing to classify them. But now it is the next, this is the time that we actually put this classification and do it the right way. Why is it important for us to do it the right way? The reason is that if we don't do this classification the right way, then we are completely disconnected with our history. And what do I mean with that? There's hundreds and hundreds of articles on this subject, looking at the depressed, looking at the flat ones and all that. And there's so much information in that. And if we cannot even classify them correctly, then we are disconnecting ourselves to that data. For example, somebody recently told me that sessile is part of the lateral spreading tumor. It is what they thought perhaps is the LST granular mixed nodule. No, if you put that sessile in there, then all of these estimations that I have shared with you of the risk of submucosal invasion and all of these, it will not work anymore because we have disconnected ourselves to our data. And let us all together now try to apply this the correct way. Thank you.
All right, thank you so much. I think there are
Beautiful.
a few questions. I would like to, I was just reading a question in the chat. That is from Tom. Tom, why don't you share when you say this is something that is overlooked, when you made a comment about the injection, so that we can understand better.
No, thank you, Dr. Raju. I would just add that the video that you showed was nice in that it shows that the beginning of that dynamic injection begins before the actuation. And the importance of that is that it allows you to reach kind of different areas of the mucosa and submucosa as you're moving the needle through it. What we see a lot in the community hospitals is not real great communication, and there's no knock on community hospitals, it's just they don't see as much of this, but they do their actuation first and then begin injecting. And depending on where the needle lands, it can sometimes not give them the best lift that they could experience by doing the dynamic injection. But that technique that you showed kind of begins with the communication of where the physician asks the technician to begin the injection process of the lift.
Thank you so much, Tom. I think you made a very good observation, and I really appreciate you sharing it with us. It took a long time for us, even at Anderson, to come to a stage where all the technicians are comfortable with the injection. And one thing that I share is if somebody wants to do EMR, they should stick with one technician for several weeks or months, so that one perfects the technique before they go to the next person. And that's what we did at Anderson about 10 years ago. You know, we took one technician who became perfect. I think that was Lieben. And then later on, other people joined and everybody learned. I think in EMR, you know, the most important point is if you could lift, then cutting is not difficult. And lifting involves patience on behalf of the endoscopist. So that is something. The second one is, you know, the other thing is you should teach people to tap rather than inject forcefully. When you tap on the syringe, you allow small aliquots of fluid to come out. And then if you find the right plane, then you should keep talking with the technician to either continue to do the tap or inject at a faster rate, depending upon how the lift is going. So, and one of the reasons I put these videos on the YouTube is for people to learn by watching, because I put the whole injection sequence without editing it, like we saw this time. I really appreciate your feedback. The next one is Scott asked about the question, what is the largest polyp you would take and block in the right colon? At what point do you say I need it to piecemeal? I think it's important to keep in mind the first principle, that is safety. Sometimes you go into the right colon and you have a perfect position, your scope is stable, it is not slipping back, you have the right angle of approach. I usually stay with a 15mm snare. That's the largest I go. And even if once I think that the polyp is benign based on the appearance, I don't worry whether I cut it en bloc or I cut it in 2 pieces. As long as you don't leave strips of mucosa in between your 2 cuts. I hope that answers your question, Scott. Next is Joseph asked the question, did you send the remaining tissue in the forceps from that heart biopsy, even though I think we did. We put it in a separate jar, I believe. If I remember, it just came back as an adenoma. So whenever I do heart biopsy avulsion of a tissue that is stuck to the wall of the colon, I always send that heart biopsy in a separate jar, because tissue that is stuck to the base of the resection site could be either because of a scar tissue tethering it, or it could be cancer, right? Those are the 2 issues. So whenever I do a heart biopsy avulsion, I put them in a separate jar. All right. All right. As we finish, any last comments, Selvi?
No, Raju, I think it was a beautiful demonstration, and I really liked Roy's summary slides, both the algorithm and then the pictorial description of the different types of polyps. I think I agree with what Sriram had said in the chat box earlier, that both of those should be up on the wall in endoscopy units. I think that would really improve the quality of our EMR technique and our reporting in endoscopy reports.
All right. Sylvia?
Thank you. Very instructive case. I don't have more comments.
Sridham?
Excellent discussion, sir. Everyone benefited a lot from today's session. Thank you.
Right. Thank you so much. Roy, anything? And then I'll answer a couple more questions that are left here.
No, very good. Thank you.
Thank you for bringing that. Actually, I want to let the people know that you watched something that Roy shared today ahead of everybody, because this is something that is going to come in publication in the next few weeks or months. Scott asked, do you have any experience with larger microtech 16mm diameter end clips? Answer is yes. I try to do that when I have a large defect that I want to bring it together. So that's when I use the Microtech clips. So, all right. I want to thank everybody. I hope you have a nice rest of the Sunday. And I'm on call next week, so we will not have a session next Sunday. So I don't want to give any inconvenience at the last minute. So we'll hold off for next week. And then maybe the following week we can decide. All right. Take care. Thank you. Bye-bye.